This podcast is brought to you by dysplasia. In the world of myelodysplastic syndromes, your bone marrow's cellular assembly line is not just slow, it's producing a stunning variety of morphologically bizarre and functionally useless cells. Here, our red blood cell precursors might be born with two nuclei. Our neutrophils might sport wildly unsegmented, peanut-shaped nuclei, and our platelet makers might be miniature oddities. It's a spectacular yet tragic gallery of cellular misfits, showcasing the body's frustrating struggle to get it right.
Welcome back to The Deep Dive, the podcast where we connect the data on the printout to the drama playing out in the patient's cells.
It's great to be back. Last time we tackled the aggressive, fast-moving world of acute myeloid leukemia, or AML, a disease of overproduction of blasts taking over the bone marrow in a full-scale invasion.
Exactly. It's a five-alarm fire. But today, we're shifting gears to discuss a group of diseases that are, in many ways, the opposite. It's not always a story of too many cells, but of cells that are made poorly. It's a slow, smoldering process, a story of cellular dysfunction and decay.
You're talking about myelodysplastic syndromes, or MDS, and I think for a lot of us in the lab, this is one of the most challenging and, frankly, interesting areas of hematology. It's not as straightforward as a 90% blast count. It's subtle. It's a disease of morphology, of recognizing the wrongness in the cells.
Absolutely. AML is a sprint, MDS is a marathon of malfunction. It's often called pre-leukemia, but that doesn't do it justice. It's a complex disease entity in its own right, with its own unique pathophysiology. Our goal today is to unravel that. We want to understand what's happening at the stem cell level that leads to the bizarre findings we see on the bench.
That's the plan. We'll start with the core concept of MDS, the paradox of a busy bone marrow but an empty peripheral blood. Then we'll do what we do best. We'll walk through the laboratory findings from the CBC and smear to the bone marrow and cytogenetics and connect every abnormal finding back to that underlying disease process. Let's dig into the strange world of dysplasia.
Let's do it. To start, what is MDS at its core? If AML is a factory that's been taken over by clones that only make one unfinished part, blasts, what's the analogy for MDS?
I like to think of MDS as a factory where the blueprints and the assembly line machinery are fundamentally broken. The factory is getting orders, the body is screaming for more red cells, more neutrophils, so it ramps up production. It's working overtime, the lights are on 24/7, but the parts it's producing are defective. They don't pass quality control.
And what happens to defective parts in a factory?
They get thrown in the scrap heap. And that is the central concept in MDS, ineffective hematopoiesis. The bone marrow is often hypercellular. It's packed with precursor cells. But those precursors are so dysplastic, so abnormal, that they're flagged for destruction before they can even leave the marrow. This programmed to cell death is called apoptosis.
So you have this incredible paradox, a bone marrow that's churning out cells like crazy, but the patient presents with cytopenias in the peripheral blood. The factory is busy, but nothing is getting shipped. That's a huge concept to grasp, and it explains so much of what we see.
It explains everything. And what causes this? At the root, MDS is a clonal hematopoietic stem cell disorder. A single mutated stem cell gains a survival advantage and starts to take over the marrow. But unlike in acute leukemia, where the mutation often causes a hard block in differentiation, the mutations in MDS are more subtle. They mess with things like RNA splicing, DNA methylation, or transcription factors.
So the cells can still try to mature, but the instructions are corrupted. The splicing of RNA is like trying to follow a recipe where some of the steps are smudged or out of order. You might end up with something that vaguely resembles a cake, but it's not going to be right.
Perfect analogy. The end products, the neutrophils, the red cells, the platelets, are dysplastic. They look weird and they don't work right. And this dysfunction is what we, as MLS professionals, are trained to spot. This is where morphology is king. The analyzer might flag some things, but the definitive clues are on the glass.
Okay, that's a brilliant foundation, a clonal disease leading to broken blueprints, causing ineffective hematopoiesis and dysplasia. Let's take that concept and walk it straight to the lab bench. A clinician sees an elderly patient with persistent, unexplained anemia and orders a CBC. What does that first printout look like in a classic MDS case?
The first and most obvious finding is cytopenias, and it's often not just one. You might see anemia and thrombocytopenia, a bicytopenia. Or you could see all three cell lines down, a pancytopenia. The anemia is almost always the most prominent feature.
And what about the RBC indices? With that anemia, what does the MCV usually do?
This is a key point. The anemia is often macrocytic, so you'll see an elevated MCV, often over 100 femtoliters. This can be a huge clue because it helps differentiate it from other causes of pancytopenia. The macrocytosis is a direct result of the dyserythropoiesis, the abnormal red cell production. It's a form of nuclear cytoplasmic asynchrony, similar in concept to what you see in megaloblastic anemia, but caused by a different underlying defect.
Right, so we have cytopenias, often with macrocytic anemia. What about the rest of the CBC, the white count, the platelet count?
The platelet count is typically low or normal. The WBC count can be all over the place, but it's often low due to neutropenia. You might see a normal or even slightly elevated monocyte count. And critically, you look at the differential for blasts. In most MDS subtypes, blasts are either absent in the periphery or present at a very low level, say 1 to 2%. This is a huge distinction from AML, where the blast count is, by definition, 20% or more.
So the CBC gives us a picture of bone marrow failure. Cytopenias, often with macrocytosis. The next step, and the most important one for us, is making the peripheral blood smear. This is where we earn our keep. What are the hallmarks of dysplasia we're hunting for on the smear? Let's go line by line, starting with the red cells.
For the red cells, you're confirming macrocytosis, but you're also looking for oval macrocytes, which are very characteristic. You might see a dimorphic red cell population, a mix of normal-looking cells and the new weird macrocytic ones, which would explain a high RDW. You can also see basophilic stippling, Howell-Jolly bodies, and teardrop cells. It's a picture of disordered production.
Okay, moving on to the granulocytes, the neutrophils. This is where some of the most classic dysplastic features live.
Absolutely. The number one thing every MLS student learns to associate with MDS is the pseudo-Pelger-Hewitt anomaly. These are neutrophils with a bilobed nucleus connected by a thin filament of chromatin. They look like a pair of glasses or a pince-nez. You can also see neutrophils with a completely round, non-segmented nucleus. This is a telltale sign of abnormal nuclear maturation.
And what about the cytoplasm of these neutrophils?
It's just as important. You're looking for hypogranulation. The cytoplasm can look pale, almost glassy, with very few or no secondary granules. An aggranular neutrophil is a striking finding. So you can have a cell with a bizarre nucleus and a pale, empty-looking cytoplasm. This combination of dysgranulopoiesis is highly suggestive of MDS.
So we have dyserythropoiesis and dysgranulopoiesis. What about the third cell line, the platelets? What does dysmegakaryopoiesis look like on a peripheral blood smear?
You're looking for abnormal size and granularity. You might see giant platelets, but just as often you'll see hypogranular platelets, which look like pale, ghost-like fragments. On a really good smear, you might even spot a micromegakaryocyte, which is a very ominous finding.
So the peripheral blood smear is a treasure trove of clues. Oval macrocytes, pseudo-Pelger-Hewitt cells, hypogranular neutrophils and platelets. It's the visual evidence of those broken blueprints. When you see dysplasia in 2 or more cell lines, MDS has to be at the very top of your differential diagnosis.
Exactly. And your morphology review is what triggers the next and definitive step, the bone marrow aspirate and biopsy. The hematopathologist needs to go to the factory floor itself to confirm the diagnosis and classify the disease.
So let's go into the marrow. We already said it's usually hypercellular, which contrasts with the peripheral cytopenias. What are we seeing in the precursor cells?
We're seeing the same dysplastic features we saw in the periphery, but now in their immature forms.
In the erythroid precursors, you see megaloblastoid changes, nuclei with strange shapes, budding, or even multiple nuclei in one cell. It's a mess.
And in the myeloid precursors?
Same story, hypogranulation in the promyelocytes and myelocytes, asynchronous maturation, where the nucleus looks more mature than the cytoplasm or vice versa. And while our rods are the classic finding in AML, you can, on rare occasions, see them in higher-risk MDS, specifically MDS with excess blasts too.
But the real showstoppers in the bone marrow are the megakaryocytes and a special finding in the red cells, right?
Oh, absolutely. The megakaryocytes in MDS can be bizarre. Instead of the normal large cell with a complex multilobated nucleus, you see small micro-megakaryocytes. You see megakaryocytes with multiple separated round nuclei or a single non-lobated or bilobed nucleus. We sometimes call them pawn ball megakaryocytes. They are profoundly dysplastic.
And that special red cell finding, it requires a special stain.
You're talking about ring sideroblasts. To see these, you need to perform an iron stain, a Prussian blue stain, on the bone marrow aspirate. A ring sideroblast is an erythroid precursor where iron-laden mitochondria have accumulated and formed a ring of 5 or more granules encircling at least 1/3 of the nucleus. Why does this happen? What's the pathophysiology there?
It's a defect in the incorporation of iron into the heme molecule. The mitochondria take up the iron, but they can't put it into the protoporphyrin ring to make heme. So the iron just builds up inside the mitochondria, and since the mitochondria cluster around the nucleus, you get that classic ring appearance. It's the ultimate example of ineffective erythropoiesis. The raw material is there, but the machinery is broken.
And this finding is so important that it actually defines specific subtypes of MDS, like MDS with ring sideroblasts, or MDSRS. We now even know the specific gene mutation often associated with it, SF3B1, which is involved in that RNA splicing we talked about earlier.
Correct. But besides confirming dysplasia, the other critical job in the bone marrow is the blast count. A meticulous 500-cell differential on the aspirate smear is performed to get an accurate blast percentage. And this is probably the single most important prognostic factor and the key to classification.
Let's break that down. How does the blast count define the different MDS categories?
According to the WHO classification, if the bone marrow blasts are less than 5%, you're in a lower risk category like MDS with single lineage dysplasia or MDS multilineage dysplasia. Once you hit 5 to 9% blasts, you're an MDS with excess blasts 1, or MDS EB1. If you have 10 to 19% blasts, that's MDS EB2.
And the magic number is 20. Once the blast count in the bone marrow or peripheral blood reaches 20%, it's no longer MDS. By definition, the diagnosis converts to acute myeloid leukemia. So our blast count is literally what separates a chronic smoldering disease from an acute life-threatening one. The accuracy of that differential is paramount.
This really highlights the collaborative nature of our work. The peripheral smear findings from the MLS drive the decision for a bone marrow exam, and the pathologist's findings on the marrow, including that crucial blast count, define the disease. But the investigation doesn't stop there. What about ancillary tests like flow cytometry and cytogenetics?
They are essential pieces of the puzzle. Cytogenetics, looking for chromosomal abnormalities, is hugely important in MDS for both diagnosis and prognosis. Certain abnormalities are characteristic. For example, an isolated deletion of the long arm of chromosome 5, or del5q, defines a very specific MDS entity that often has a good prognosis and responds well to certain treatments.
On the other hand, there are bad news findings, right?
Right. Finding a deletion of chromosome 7 or a complex karyotype with 3 or more abnormalities is associated with a much poorer prognosis and a higher risk of transformation to AML. So the cytogenetics lab provides critical risk stratification.
And what is the role of flow cytometry? In AML, it's all about identifying that big blast population. Is it the same in MDS?
It's much more subtle in MDS. You're not usually looking for a huge blast gate. Instead, flow cytometry is used to find immunophenotypic evidence of dysplasia. You're looking for maturing granulocytes or monocytes that are expressing markers they shouldn't or aren't expressing markers they should. For example, myeloid cells aberrantly expressing the lymphoid marker CD7, or showing abnormal patterns of CD13 and CD16 expression during maturation. It provides objective evidence of the dysplastic process.
So, to bring it all together, the diagnosis of MDS is a synthesis of all this information. You need the peripheral cytopenias from the CBC, the morphological evidence of dysplasia on the smear and marrow, the blast percentage from the marrow diff, and the supportive evidence from cytogenetics and flow cytometry.
And all of that data, every piece of it generated in the laboratory, gets plugged into prognostic scoring systems, like the IPSSR. This system takes the blast percentage, the specific cytogenetic abnormality, and the severity of the cytopenias and calculates a risk score. This tells the clinician if the patient has low, intermediate, or high-risk disease, which directly guides treatment. It shows how our quantitative and qualitative data has a direct impact on patient care.
It's a fantastic example of integrated diagnostics. We start with a vague clinical picture of fatigue in an elderly patient, and by the end, we've provided a highly specific diagnosis with a detailed risk assessment. We've taken the story from a stem cell with a corrupted genetic blueprint all the way to a concrete treatment plan.
And it all hinges on recognizing that fundamental wrongness in the cells. MDS is the ultimate morphologist's disease. It's a testament to the fact that even in an age of automation and molecular testing, there is no substitute for a well-trained eye looking at a well-made blood smear.
I couldn't agree more. We've seen how the pathophysiology of ineffective hematopoiesis manifests across every department in the lab, creating this complex but logical pattern of results. It's a story of a factory working hard but producing nothing but scrap.
A perfect summary. We've covered the inferno of AML with a factory that's been overrun. Today, we've covered the slow decay of MDS, the factory with the broken blueprints. I think it's only logical that our next episode tackles the third major category of myeloid neoplasia.
You must mean the factory where the off switch is broken, leading to massive overproduction of mature cells.
Exactly. Next time on the deep dive, we'll aspirate more bone marrow and explore the world of the myeloproliferative neoplasms, or MPNs.
I can't wait. It's a great place to wrap for today. Thanks for listening.